that I was only informed that I was substituting this speaker this morning, last night at the dinner. So I had to try to do it during the night. So I apologize for any little problems that might be there. Well, the title is Changes and the Impact on Practice and Training in Cardiovascular Thoracic Surgery. And then the Norwood operation for the hypoplastic Kelvin syndrome, and then there is MACE, just a couple to illustrate. And then the appearance of new technologies, especially these two, video-assisted surgery, sorry for being in Portuguese, that to happen, robotic surgery. I found this paper from Dr. Verheer's unit, Cardiothoracic Surgery Residency Training Past, Present and Future. Now they come to these conclusions. A dramatic transformation of cardiothoracic surgical education has evolved over the past few decades. Like the radical advances we have witnessed in surgical therapy, surgical education requires creative and perhaps disruptive changes if we are to continue to produce well-trained additions to our professional ranks. Now, this paper is from 7 years ago, but I think it's still quite actual. We're still discussing this problem. The European Association for Cardiothoracic Surgery has produced this original publication in 2012, which about a uniform European training system in cardiothoracic surgery, asking if it was the time. Indeed, it was the time. The reason for this in Europe was not only the changes that had to be included in the training programs, but also to try and to make the training programs throughout the Europe, different countries, uniform so that they could be free traveling. It's complex, we cannot read, but they come with different solutions for the training in the different phases, so that even though there was still some freedom for different countries to individually make slight modifications, the framework was the same. So after this, you would have sort of a European title that was valid for all patients, for all people, all surgeons working in European countries, especially in European Union, but not all, only. In the United States, the problem has also been discussed. And there was this survey after the in the early of this century, early years of this century, and these authors in a survey with the residents, 2,000-something residents, they found that in mixed adult cardiothoracic practice, which was 20% in 2014, 2003, so you see, and 52 in 2003. So you mean in these 11 years there was a drop from 52 to 20% of people who did not do the two specialties, let's call it that way, cardiac and thoracic surgery, and more people plan to do additional training. An increase from 10 to 47%, and then the frequency of simulation, and I'll come back to that later on, increased from 1% in 2009 to 24% in 2012. And more residents were prone to recommend this specialty to newer residents. And they conclude that with the evolution of cardiothoracic surgery over the last decade, residents' training and career paths have changed substantially with increased specialization and simulation accompanied by increased resident satisfaction and improved job market. Not all the surveys had the same results, especially about the satisfaction of the people. But this is what they found, that there was an increasing number of people coming to congenitals, but a dramatic drop in people coming from the mixed cardiac and thoracic, just to one or the other, while general thoracic had a slight increase. And in the end of this period, there was a slight increase in the number of people, or the percentage of people who thought they were adequately trained or prepared for the boards, as compared to a slight lowering of the board pass rate. Now, in response to a paper published in the Journal of Thoracic and Cardiovascular Surgery, Michael Borger described, put this question mark about the future of cardiac surgical training, a survival guide. And he said that the current generation of cardiac surgeons has an obligation to our future colleagues and to their future patients. Alterations to our methods of training and to our methods of practice will be required to deal adequately with the rapidly evolving field of cardiac surgery and structural heart disease. Subspecialization will be absolutely essential for future cardiac surgeons. The days of cardiac surgeons performing all types of cardiac procedures and even pediatric or thoracic operations will be gone in the foreseeable future. Now, the paper to which this editorial report was this one from Dr. Pelletier, and was titled From Suture to Wires, the Evolving Necessities of Cardiac Surgery Training. They draw the attention not only for the new residents, but also to established surgeons. Because we have been talking about how to train the new residents. The question is that how to train people like Manuel Antunes. Perhaps Marco Turina does not need retraining, but there are a lot of things that we don't know, you know. The evolution of science goes so fast, it's important. A generation of competent and talented surgeons whose training predates the explosion of catheter-based therapy did not acquire endovascular techniques during their training or fellowships. Many wish to acquire these skills either out of their own interest or to support our teams at their institution. For this cohort of mid-career or senior surgeons, taking a full year to retrain in a traditional fellowship may pose economic and family barriers that render this option impractical. And this is a block for progression in many units. Now, we have now new training methods, wet labs, for example, on your left panel, and see art in a setting where you can, I can see from here, I think, do an aortic valve replacement, or you can train in simulators, as you see on your right-hand panel. This did not exist when I trained, and indeed only came into being in the last decade. And you have even a more newer thing, which is virtual reality. You know, you have a team of the people with a model of the heart constructed by echo, by other forms of MCDTs, which can be used for the participants in the surgical team to prepare what they're going to do to the real heart. Now, it's clear now that there is an increasingly frequently used trend, or increasing frequency trend to simulation facilities, which you can see here from the blue bars, and who use it frequently, and those people in red who use it at least occasionally. Now, in Europe, we had a problem at the beginning, which in part triggered all these modifications, which was the Working Time Directive. Suddenly, the European Union decided to put a lot of constraints on the weekly working hours. As you can see, you cannot do more than 48 hours a week. A minimum daily rest period for every 24 hours, a minimum of 11 consecutive hours of rest, a minimal weekly rest period, and other limitations. Now, if I stop here a little bit, I remember when I started my internship in Johannesburg in South Africa, I often worked 36 hours, rest for 12, 36 hours, rest for 12. It's an exaggeration, but I can see how you can do it with 48 hours, which is just 8 hours a day. It's probably not enough. You're not there at the time when the most interesting things happen. So, and this created a lot of discussion in Europe. The role of informal workplace learning, for example. This comment said that limiting doctors' working hours to 48 hours per week has caused recent controversy. The Royal College of Surgeons of England itself came up into that discussion and raised many doubts about the possibility of a proper training in this limitation of time. However, they say modern education theory emphasizes that the power of informal workplace learning is in postgraduate education and the essential role of experience in training future surgeons. There are many papers, many discussions about the effects of reduction of surgical residents' working hours and implications for surgical residency programs. A narrative review comparing with different countries. A reduction in resident work hours has salutary effects on the perception of quality of life, of course. It's a better life, I understand that. And basic education for surgical residents. These benefits may come at the expense of patient care, particularly continuity of care. This study did not directly assess patient outcomes, but the perceptions of caregivers suggest that patient care may be compromised. And that's a problem in itself, because what you have is that the residents are the ones that take care of the patients, which should not be exactly that. They should be at least accompanied by the surgeon. So patient care itself becomes less, gets a lower quality when this happens, and especially if you take the residents from there. In this study from Brazil, also a survey, current residents present lower job satisfaction and more criticism of teaching techniques. These changes compared to previous results match the profile of Generation Y, that's what is called now the millennials, who is more iconoclastic when compared to previous generations. So not even the residents in some countries are not happy with the new methods. Now, if you have to think about asking the residents to change their attitudes towards their training and towards the needs of their training, you also have to look into the trainers, changing teachers' attitudes and professional skills by involving teachers into projects of curriculum innovation in Germany. This paper brought this slide, this table, which shows the new concepts, the knowledge about teaching and learning, developing practice, training leaders, and documentation of teaching practice. And you can see that it's a vicious circle that can lead to improved quality or decreased quality of training. Now, I left for last, because there isn't much time for more, the question of the surgeon and the residents and the new trainees in the hybrid OR, let's call it hybrid OR cath lab. I'm a little bit skeptic about it, you know. This was initially thought to be essential because of the need, for example, for emergency cabbage after a failure of the PCI. Now, as you see, the evolution of this, basically there is no emergency surgery now after failure of PCI, except for the occasional rupture of the epicardium. So this is not it. But there are other needs for the hybrid rooms. To me, the role of the cardiac surgeon in the cath lab would be, it can be one of these three things. The simpler, which is the most common, the standby operator is there to back up the interventional cardiologist should something wrong happen. And the second is himself becoming an interventionalist or a hybrid cardiac surgeon as it is now. And the third one is to be an innovator. And we've got a good example of that. That's Francesco Maizano, who is now a completely devoted surgeon into the cath lab. The question is that I'm not sure that he is still a cardiac surgeon. It's a new profession that we are creating. So we have to, of course, enter that into our plans for training in the future. But perhaps you need to create a new specialty there for these cardiac surgeons. They certainly do not qualify for the normal classic OR that we have got. Thank you very much.
Thank you very much, Manuel. If we have time, we will discuss these important problems at the end. I would like to introduce the next speaker, Professor Yutaka Okita from Kobe in Japan, aortic surgery in endovascular stent era. How are the changes?
Good morning. This way or this way?
You have to point. That's right.
That's right.
Yeah.
Okay. So this is an annual survey of Japanese Association for Thoracic Surgery for thoracic aortic aneurysm all over Japan. So pink one is ascending aorta replacement, yellow is arch, and blue one is T-bar, endovascular. As you can see, the T-bar is dramatically increased since 2014. The commercial available stent graft was drawn in the market. And this is hospital mortalities of 20,000 cases. With acute type A dissection is 11.3%. And non-dissection elective surgery mortality was 4.3 in Japan. And as for T-bar, hospital mortality was relatively low. All of 5,000 cases in non-dissection aneurysm is only 3.7%, and the ruptured aneurysm is 20%. So this is a result of whole of Japan. As for descending or thoracoabdominal aortic aneurysm, the trend, mode of surgery was dramatically changed. The gray bar is a T-bar, and red one is the open thoracoabdominal aortic aneurysm, and the yellow is a descending aortic aneurysm. So number of descending aortic aneurysm is decreasing. Thoraco open is stable. However, endovascular surgery for these lesions are very, very rapidly increasing. As for my experience in Kobe University, actually, replacement of descending aorta, open surgery was virtually gone, replaced by the T-bars in the red lines. And open thoraco and the arch is still increasing. So this is my personal experiences. So my indications for T-bar is class 1 is patient is not fit enough for open surgery. This is number 1. Second is anatomical amenable, such as localized descending aortic aneurysms, and acute complicated acute type B dissection, such as a rupture or pain or malperfusions. And acute non-complicated aortic dissection type B with growing risk is a little bit concerned about the late result, but that's still okay. 2A. And sacral arch aneurysm is good for endovascular. However, chronic type B or aneurysm with require more than 2 debranches, or microtic thoracic aortic aneurysm is I don't recommend to do T-bars. So these are lesions, aneurysm or penetrating aortic ulcer or a dissection, so it's fit for endovascular surgeries. So how about the TIVA for descending aorta? This is the meta-analysis of 6,000 cases, 42 studies. 30 deaths is favor endovasculars. However, 1 year death is reaching 1, as you can see this portion. So long-term result is reaching to equal in both ways. And cold complications favors endovascular, and the stroke, there's no differences. Another meta-analysis shows us 30-day early death is favor for endovascular. However, 5-year death, shows no differences. And the cold complication is favors endovascular. And stroke is the same. So both meta-analysis showed similar result. Early is okay for endovascular, but the later is questionable. So this is a nationwide of United States analysis of 11,000 patients, and they reported the complication or early result is favor of the T-bars and for descending aorta. So my personal experience until 2015 is 200 cases. And survival is similar in both TIVA and open surgery groups. And the freedom from MACE is a little bit better in open surgery group. However, this is not significant. And TIVA for distal arch. Distal arch have some special problem because it has a concave and a convex figures, and the neck is short, and usually need a debranching for neck vessels, and they tend to occur stroke, or fixation is a little bit difficult, and there is unpredictable aneurysm exclusions, and also they have spinal cord ischemias. So complex surgery repair consists of 3 methods. Is the 1 classical open surgical repair, and 2 endovascular, or 3 hybrid. So each modality have advantages and disadvantages, and the clinical result is similar now. And this is again meta-analysis for arch debranching, 600 cases. So early death is 12%, stroke ratio is 7%, and the cold complication is 4.3. So this is not so better. And also, if you cover the left subclavian, they cause several serious problems. And I have 1 cases who have endovascular with debranching, and the aneurysm still continue to grow to 100 millimeters. So this is Dr. Takano's data. He's from Osaka University. So aneurysm sac, some patient is okay, but however, several one is going to continue to grow and the ruptures. This is actual data. And this is open surgery for aortic replacement, and in major institutions. And the yellow one is that they use deep hypothalamic circulatory arrest only. The other papers are using antegrade cerebral perfusions. And generally, transient neurological dysfunction, stroke, and mortality is, I think this is acceptable for complex surgeries, open. And we have done over 1,300 cases in Kobe University's arch surgery, including 900 total arch replacement. And the majority, we have antegrade cerebral perfusion as brain protections. And initial result is, of course, it is higher in acute type A dissection groups. The overall mortality, hospital mortality was 5%. And the stroke ratio is also higher in acute type A dissections. So how about the extensive one? Extensive means patients require arch replacement or descending aorta. So there's 3 options: open surgeries, brave one, and staged repair using elephant trunk, and hybrid repairs. So we focus on the one-stage operations because it is done one time, and the patient is relatively young, 63, and we had 61 cases from left thoracotomies. And extension of a replacement is ascending, route to ascending and descending, route to ascending and descending, arch to descending, or arch to thoracoabdominal aortas. Anyway, this is a big operation. However, this is the diagram from the left thoracotomies. We do a total arch replacement from the left and replacing a descending aorta. This is the one option, one of the cases. This one. And this is the result. We had a hospital death at 7% and late death 3. So although the result is not ideal, but the patient had no sequelae if he survived the operations. So TIVR for aortic dissections. This is a diagram from IRAD. And acute type A, B dissection, endovascular, is superior than other medical management and surgical management in the early stage. This is acute type B dissections. And medical management has higher in hospital mortalities. And open surgery is worse. Look at this, 69% of mortalities. However, TIVR for acute complicated B, they have acceptable, say, 10% or 8% mortalities. So we recommend TIVR for acute type complicated B. And there is one meta-analysis comparing TIVR and the open, and also there are superior early death mortalities. And the choroid ischemia is a little bit lower. However, 5-year survival is a little bit similar. And the famous INSEAD trial or other sub-trial justified the TIVR for uncomplicated type B. However, there is the risk of new intimal tear formations and multiple entries and unknown entries. And this is also comparing type B aortic dissection with aneurysm formation, comparing open and the TIVRs. And however, the open surgery have 60% of thoracoabdominal aortic aneurysms. So the intervention is higher in the TIVR groups. I skipped this one. So risk predictors for aortic events in acute type aortic dissection type B is a patient have a larger aorta, 40, and the fourth lumen is over 22, and the rapid expansion, patent fourth lumen, and the partial thrombose one, and sacral formation, a larger tear, single, so on. So these kind of patients with chronic phase in type B I think we suggest to do open surgeries. So there are many techniques to fix the false lumen in chronic phases. However, it is not always work. And sometimes they have a retrograde type A dissection require emergency surgeries and with higher mortalities. This is an open surgery for after T-births. Sometimes they are get infected and needs to removed, and of course the early mortality is not so good as in the initial one. But however, we'll see more and more incidents of T-bar removal because of mainly because of infections and end leaks. I think I'm going to stop here. So, thank you.
Thank you very much. We'll discuss it then in the end. The next speaker will be Dr. Jeon from Seoul. I hope I pronounced your name correctly. Thoracic surgery in the area of VAT and adjuvant therapy. From the heart to the lungs.
Thank you, Chairman, members and guests. This session, I know this session is how to teach, how to train the cardiothoracic surgeons. I'll focus my presentation, how paradigm is shifting in the era of the VETs or the adjuvant therapy, so how we should do for training our next generation. Let me introduce the important paradigm shift during last decades. So first one is low-dose CT, low-dose CT screening. Because of the low-dose CT screening, we can find many earlier stage lung cancer. So the limited lung resection is increasing, and the number of the lung cancer surgeries is also increasing. And we can find many lesions at the stage of the ground, so-called ground glass opacity. So the navigation procedures are very rapidly advancing. The other important paradigm change is minimally invasive procedures. Last decades, the VETs and robotic surgery is very rapidly increasing, so many countries, many hospitals. Also, application of cryoablation and radiofrequency ablation is also increasing for the ground glass opacity for lung cancer. And the other new treatment modalities are improved. SBRT is challenging for initial radiation therapy for early stage lung cancer, and the immune checkpoint inhibitors make the new paradigm shifting for chemotherapy. And the next generation sequencing provide large of the genetic information of the lung cancer, so we can provide a very personalized precision medicine. So we have a lot of the discussion during last decades about the efficacy, especially cost effectiveness of the low-dose screening for lung cancer. But recently, most developed countries adopted the low-dose CT, best tool for early detection of lung cancer. Also in Korea, we are applying the national lung cancer early diagnosis tool for low-dose CT for risk populations. So this is the trend change of the lung cancer surgery and the lung cancer cases. Green bar is the number of the new lung cancer patients, and red bar is the surgical cases in my hospital. Last decade, the proportion of the surgery is around 25 to 30%. but recently, this decade, about 35%, and even is approaching the 40% recently. So surgical cases increasing. And also changing trend, we can see that the limited resection cases increasing. Formerly, last decade, lung cancer surgeries were usually lobectomy or even pneumonectomy, but recently we can find them very limited cases for potential pneumonectomy case, and recently lobectomy or segmentectomy or wedge resection. You can see that the limited resection cases increasing, and the subsolid tumors, not solid tumors, subsolid tumor proportion is also increasing to the almost 40% of our surgical cases. Formerly, as you can see, the left photo, the big thoracotomy, hands inside of the thoracic cavity, but the wedge, initially 4 or 5 ports or 2 ports, recently uniport, even subxiphoid approach, and many cases of the robotic surgeries are applied. So now we had a lot of the discussion and evidence collection for wedge. So now it is recognized and accepted. Wedge lobectomy. Wedge is a safe and effective procedure for earlier stage lung cancer, but recently, even for the advanced lung cancer, many centers are performing lung resection by wedge. So this is the report data from Intuitive Surgical. So as you can see, that the robotic case is increasing to 20%, and open surgery is decreasing to the 40%, and the wedge is about 40% in many institutes. This is our data. Last year, we performed the 705 cases primary lung cancer surgeries. Recent 5 years, our proportion of the wedge is more than 95%. Almost all cases are done by a wedge for lung cancer. Another important game changer for management of lung cancer is the immune checkpoint inhibitor. It is very important changing in the next decades for lung cancer chemotherapy. Starting from the Adjuvant phase 3 trials for advanced lung cancer, immune checkpoint inhibitors showed a very excellent outcome. So even now, immune checkpoint inhibitors are applied to even neoadjuvant therapy before lung cancer surgeries. So NEJM reported the tumor response rate for neoadjuvant therapy is reaching almost 45%. So we are challenging surgery after immune checkpoint inhibitors. In the surgical findings, more hilar adhesion or inflammation is noted during surgery. Initial challenge was done by Memorial Sloan Kettering Hospital, but their cases were even tight adhesion. They can do, surgery can be done by safely. So at this moment, we need to think about what surgeons should do. Formerly, surgeons just focusing on the surgery, but we should know, now surgeons should know much more about the new chemotherapy modality, how these kind of new cancer treatment regimen is attacking cancer cells, know the mechanism, and we need to know the mechanism of the treatment of the SBRT and the NSX. But even the chemotherapy is advancing, and SBRT is applied to the early stage lung cancer. I think surgeon's role is still important and even bigger in the future. So at this moment, what we need to do, I'll introduce my hospital education system. We are providing surgical skill education for young latents. So we have the good animal laboratory facility. We provide regularly vaginopectomy and aortic surgery for animal, and this is 3D printed. We can teach how to mental surgery. So this is very important for young doctors to be exposed and make a training for basic skills. As you know, it is very hard for resident to perform surgery. Formerly, when I was resident, I did the largest procedure by supervisor from my professor, but recently almost all procedures should be done by professors. So we need to provide opportunity to young doctors by surgical animal laboratory. And we also, young doctors should be very friendly to new technology. There are many new technologies are coming, so young doctors, even fellow, even professors should be watching how the new treatment modality is coming. We need to have interest to contact the new procedures. And we also provide the cardiothoracic surgery research camp every year. So my purpose is to make my resident to be exposed not only clinical activities, but also basic researches. So even resident is very participate basic research, very small part because of the time limitation of the working hours, but I wanted to expose them as much as possible for how our related basic research is important to be the professor. So I think next generation should be familiar and watching for how future of medicine is changing. So as the healthcare, cloud, big data, mobile, Internet of Things, artificial intelligence are very important keyword for future healthcare. So our next generation should be very watching and a bit familiar with how future will be changing. They want to. I'm very happy to know that my fellows, they are very interested in big data collection. Sometimes they come to me, so I'd like to collect the ICU vital data to make the artificial intelligence application, how for expected cardiac risks. I'm very happy to that kind of response. Also, genomics is the future of the medicine. We need to teach resident for how genomic information is important for our future. This is not the basic science job, not the job of the oncologist. The surgeon should know, I think, the genomics very well. So also, I made the new operation room named the Smart Operation Room. This room has a very cutting-edge equipment, 4K, 360-degree cameras, 3D and the voice controlling, and the telepathology. So all these surgical materials will be uploaded by YouTube, and I'm providing the educational material to our resident, not only in my hospital, to also other hospitals, young doctors. So I hope CT, cardiovascular thoracic surgeon training in the era of something. So anyway, as a surgeon, as a clinician, I think they should know the basic knowledge about surgery and cardiology, pulmonology, oncology, even physiology. And we need to focus skill education from the basic skill to innovative procedures to provide the best quality of procedure. And young doctors, we should make them to be exposed to the modest technologies, especially information communication technologies. And we'd like to let them make a thinking as innovative. So I hope this next generation will be, we can nourish our next generation as innovative and academic surgeons. Thank you very much for your attention.
Thank you very much, especially for keeping well on time. The next and last speaker will be Professor Turina. We all know him. Will speak about worrisome trends in scientific publishing. He has a large experience with publishing. He was chief editor of the European Journal for a decade, almost a decade.
Good morning, ladies and gentlemen. This is a subject which kept my attention for quite a while because in my life experience, I was cardiovascular surgeon by training, but in the last 25 years, most of my experience was also not only in surgery, but also in editorial work for the number of journals. This will not, can you help me? This doesn't work, can it? Pressing one? No, pressing one.
It's a battery.
It still does not work. Okay, so that would be my theoretical conflict of interest on the various editorial works, and this gave me an insight into the problems of the publishing. You all learned the so-called pyramid of scientific evidence, that the top of the evidence has randomized controls and double-blind studies. And the rest of it is more or less level B, and the case series and case reports as level C, practically worthless in science. I deeply disagree with this method. For instance, the first operation, composite graft replacement of the ascending aorta, was performed by Hugh Bentel in 1968. We all do this operation now, but it was a single case report which really changed the way the surgery went. And so it is not useless as it is shown here. I have took some time to analyze the first reports of comparing PCI to coronary bypass grafting. In these studies, you've seen Rita and Gabi and East and Cabri. There have been 91,730 patients involved. Out of this material, only 4.9% of the patients were really involved in the trials, which is of course ridiculous because the results from this 4.9% are extrapolated to the whole population with a coronary artery disease. And then you look at the now present very current Stent percutaneous intervention coronary bypass grafting for severe coronary stenosis. It is now called as a Syntax study. Syntax claims that they accepted all comers with left main and 3-vessel disease. But in his 2 years, in 85 high-level centers, only 25% per year were accepted. In the centers which do several hundred patients with a similar anastomy, it is obvious that the huge selection was taking place. It was not done by the surgeons, it was done by the cardiologists prior to entering the trial. There was a very interesting article which I highly recommend you to read. It is very difficult to read it. You have to read it about 3 times to try to understand what the author is really trying. The data fabrication and other reasons for non-random sampling. He has analyzed data from the leading journals, Lancet, New England Journal, JAMA, and he has found out that the starting level of the groups in the comparison groups is really not randomized. They do not fit to the randomization. There are some significant changes deviating from the baseline, and it is obvious that the selection of the patients, the sampling, was not random. And there was either not properly conducted or not accurately reported. Probably, again, problem of selection of patients for the trial. There is also a problem doing and the intention to treat. I somehow object to intention to treat. I know that statistically it's the only way to do it. But the results is based on the analysis only of the treatment arm where the patients really were assigned due to random allocation, and not on the treatment received, which is in a way idiotically, because you are considering the patients as surgically treated, although they never received the operation. Looking at the older trials, for instance, of this European coronary surgery study and CAS study, you can see that the crossover trial, the patients who were assigned to the medical group, and 40% after 10 years they were in surgical group, but they are still counted as conservatively treated. This is the intention to treat analysis. And this is one very popular cartoon, what the intention to treat really involves. It's the patients who did not receive treatment, left without follow-up, died, discontinued therapy, but it's all thrown in and finally comes out a statistic of the intention to treat. The problem of the prospective randomized trials is shown very much in the Excel group. This is a tactics which many scientists now use, grouping the outcomes to achieve the desired results. For instance, you put mortality and stroke and myocardial infarction. There is nothing really, this is really different if the patient dies or he had just a slight stroke, but it is counted as one. And then instead of using just the important one, the mortality. And then the second problem, I will show you the variable definition of events of myocardial infarction. This is what caused now huge discussion about the Excel trial. And then I will show you again example presenting results at the arbitrary intervals, because 3 years it looks good. For the PCI, 4 years it doesn't look good. But present in the New England Journal, the data was presented at 3 years. In the last 3 weeks, there was a huge discussion about this Excel, even by the BBC in the program, in the evening program. It was discussed when the European Association of Cardiothoracic Surgery withdrew official support from the European Society of Cardiology recommendation for the 3-vessel disease and left main. What has happened, for instance, in Excel? This is the 3-year report mortality in New England Journal of Medicine. I was member of the Data Safety Monitoring Board, and I have access to the data, and I can speak about it because my role was canceled. The Data Monitoring Committee was dissolved. Survival statistics shown to them 3.5 years look very different. There is an increasing mortality, and this was called immediately in emergency session of the Data Monitoring Committee, and we discussed it with trialists, and they told us that nothing can be done. The paper was already accepted for New England Journal. It's going to be published as such. But this is a huge increase in the mortality of the PCI group after 3 years. In syntax trial, there are numerous errors also shown that they analyzed up to 20 subgroups. And in such an analysis, and this is the basic statistics, you are not allowed to use a simple p-wave statistic. Subgroup analysis requires a so-called Bonferroni correction. And this is the paper which I always showed all my residents. The statistical, the error when you do a subgroup analysis, the line consists really of the line where false findings can be found. It shows that the p-value of 0.01 we all accept as a very good statistical result, practically certain. It is a false result of at least 11%. And the p-value of 0.05 shows in a multiple subgroup analysis that the error will be 29%. So 29% chance that you will find something significant, but there is no significance. The problem of the changing MI, myocardial infarction definition in this syntax and Excel trial caused a lot of problems. It was shown in a trial coming from South Korea, where the results of PCI coronary artery bypass grafting in the same group of patients when analyzed by 3 different definitions of the myocardial infarction, using so-called second universal and third universal definition, where there was no difference in myocardial infarction. But when they applied definition of the Society of Cardiac Intensivists, American Society, suddenly there is a huge increase in the myocardial infarction in coronary bypass grafting group, because they count every increase above the arbitrary value of troponin release as the myocardial infarction. You all know that the prolonged cross-clamping will have some troponin release. There is no escape of that. But counting this as a myocardial infarction and equating this to an infarction which happened 3 months later with the hospitalization, it is a statistical error, but that is how you can manipulate the results. The Excel results were looked at recently. It was published, I read it in Medscape, as a matter of fact, that looking at the results of the Excel trial in a different way, looking at this coronary artery bypass grafting and myocardial infarction only to the strict definition of a myocardial infarction, third definition, suddenly you will find the results are much better in surgery group than in the PCI group. So this just shows how the results can be manipulated in a not so subtle way. The one thing which worries me is the difference of outcome of trials when they're supported by the industry. In yellow are the trials supported by the university. In red are the trials supported by the industry. And the industry trial, as a rule, have a more positive outcomes, especially when dealing with the devices, when more than 80% for the outcomes will be positive. Industry supports the trial, and only 60% if it is a university type of trial. So there is an influence on presenting results. And then we are faced with the quandary of non-inferiority trials. I hate non-inferiority trials. They came relatively recently. And non-inferiority trials shows you that it can be previously, you were either, it was a improved trial, it crossed the line of no difference, then it was, trial was positive, or you would have results which will be less good, and there will be negative results of the trial. But now we are faced with a non-inferiority problem. And this non-inferiority problem basically depends all where you draw the line of the non-inferiority. There is no mathematical rule where to put this line. It is just decided by the trialist before the trial where to put the non-inferiority. Now, by moving this line left and to the left and to the right, you can produce practically any results you want. And this is problem. This is why the reason why this the non-inferiority trials have exploded in the recent years. You can see the rapid increase of non-inferiority trials. It is so convenient to have a non-inferiority trial because you can prove practically whatever you want just by changing the so-called line of inferiority. Oops. The final comment is about the level of prevalence of SPIN in published cardiovascular randomized clinical trials. SPIN is a polite word for propaganda and achieved through knowingly providing a based interpretation. It's come from Merriam-Webster interpretation. These authors have found then in the systematic review, 93 reports from high-impact journals, positive SPIN showing statistically non-significant primary outcomes as a success of the trial was seen in 57% of the abstract and 67% of the main text. So one has to be reading very carefully not to be swayed by the secondary results. Look at the primary result, like mortality. So to summarize my own pessimistic summary of the exploratory work with the recent 20 years shows that statistical war against fraud is now over and the cheaters have won. It is not mine. It comes from the professor of mathematics in Cambridge in his book Fourier Analysis. Thank you for your attention.
Thank you very much with these interesting thoughts. We would have 6 or 7 minutes for discussion if you want of any one of the 4 papers. We all presenters in here. There are a couple of other questions, please.
I'm from Bangalore, India. We have been listening you, watching you for so many years. I wanted to ask you a question. The answer should be from your wisdom of last so many decades. Now, everybody pressurizes us, senior people like me, that the evidence-based medicine. And we come from an era where we know that our experience is not to be belittled, our gut feelings are not to be belittled. Where do we stand when we treat more complex disease today? And do we really stand by the evidence-based medicine? Because when it goes to the court of law, the argument will be always the evidences that is there in the literature. So I'm very confused that what does a senior surgeon today who has a large practice believe and do?
Well, I think the only answer to this is that each center and each country has to establish its own database of evidence. It has been several times visiting Francis Smith, South Africa. It is totally different material which you are dealing with, and there is no way of extrapolating results taken from United States in coronary artery grafting to the population there, or even to the population in Switzerland. I think the only way is for the local surgical organization, national surgical organization, to establish their database and cooperate with the cardiologists to have the true meaning and the true statistics.
And it's also important that the judges of each country also should understand this, that the so-called evidence of many times supported by industry is not sacrosanct before they write a judgment.
Well, this is just my own opinion, and it's not opinion, it is based on the fact. This was published in Journal of Medical Association about 12 years ago, and it is rarely quoted. But this is the truth, that there is a spin towards positive results if you have an industry-supported trial. When you talk to the people from the industry, they say, of course, we will not be supporting the trial which is futile, which would be obviously negative. So it is not quite that they are cheating, but they are intending to support the trial where they will see a positive benefit for their own sake.
My name is Byung Moon. I'm from Toronto, Canada. I've been listening to you and very impressed with your presentation. As I read my journals, I'm always confused where the truth lies a lot of times, because I've also had statisticians tell me that they could literally make any study statistically significant at times, which was a very depressing news. So as far as a layman like myself reading a journal, where do I put my weight as far as the industry sponsors research and also non-inferior studies compared to prospectively randomized multi-centered trials?
Well, I think the answer is very simple. You have to read very carefully the methods of the trial, not the results immediately. Go to the method and you will see if there is any sub-selection taking place. And if there is no claim of sub-selection, then you just look at the logics of it. For instance, in the Excel trial, it was obvious that they were doing a high selection of the patients, but it is still claimed. It is on the New England Journal accepting all comers. They're accepting all comers which they decided to be comers.
So in intent to treat papers, when they actually cross over, that's one thing because it's intent to treat. But the ones who drop off from the study because they are not happy with their final selection, do we leave those in the intent to treat, or do we just take them out? Because there have been several studies that actually take them out completely.
Well, it all comes to yourself. You must be critical enough, and you are allowed to make your own opinion. I made my own opinion on several trials which I served on. So this is allowed to be taken, and it should be said openly. I think that is the only way. You have to judge for yourself and not accept a nicely written paper in New England Journal.
Francis, quick, short question.
I'd just like a question to you, Dr. Jean. Can you just give us a little bit of an idea of how you conduct your low-dose CT scan screening programs?
So we had many trials about the efficacy of CT screening for lung cancer. But the problem was one is the cost, and the other thing is exposure to radiation. So, but the final recent data is supportive to low-dose screening, but not general population. For the risk population, for example, is smoker, ex-smokers, age over 40 or 50 years. Korean government starting to provide the lung cancer screening for only risk groups. As you know, the lung cancer is the #1 killer, not only for men, but also women. So it's very effective tool for early detection, early stage. Yeah.
Gentlemen, we have to conclude this. We are at the end of our time. Thank you for your attention.